Thank you, Mark. These are my disclosures. Sickle cell disease is a rare hemoglobinopathy with an outsized influence on emergency departments and hospitals, especially in urban areas in the United States. It affects approximately 100,000 individuals. The pain of sickle cell disease is vaso-occlusive in nature at the beginning of its course. It's nociceptive, it's ischemic, and inflammatory mechanisms are involved. Then later, pain may become acute or acute on chronic as even organ damage occurs in the hip, leg ulcers, and the like. Still ischemic, still nociceptive, and it's multilocal, strangely so, even during the acute phase. Bilateral pain is the norm when a vaso-occlusive crisis, which is the hallmark of sickle cell disease, occurs. I and colleagues conducted the pain and sickle cell epidemiology study. This data became the basis for 2 consensus panels, which have now met and published their results. The first consensus panel actually was on chronic pain, but I'll show you the last one since we're talking about acute pain today. We came up with a consensus definition, as you can see here, and allowed for 2 subtypes, one without any painful comorbidity and one with painful comorbidity. We made the point that acute pain in sickle cell disease, and this will be a theme throughout the discussions about sickle cell disease, sickle cell disease pain may occur with or without chronic pain as a background. So acute vaso-occlusive crises are the tip of the iceberg, and most pain in sickle cell disease is actually chronic, daily, or almost daily pain. Acute manifestations of sickle cell disease with crises occur more often in patients who have a background of chronic pain. The NHLBI convened an expert consensus panel, reviewed 32 trials, 34 observational studies, and 30 case reports, and came up with recommendations of highest quality evidence and strongest recommendations that one should use opioids within 30 to 60 minutes of arrival in the emergency department for a vaso-occlusive crisis. There was less compelling evidence about the use of nonsteroidal anti-inflammatories, and also less compelling but a significant amount of evidence about the use of around-the-clock dosing versus intermittent dosing as needed for inpatient management of vaso-occlusive crises. Now, chronic pain in sickle cell disease must be discussed because of what I just discussed about the interplay between acute and chronic pain. The types of evidence to help define and describe chronic pain are just now emerging. The features of chronic pain in sickle cell disease seem to be similar in many cases to diseases where neuroplasticity and central sensitization dominate. So the time course often of sickle cell pain is that as a child, when there's pristine protoplasm, you get acute vaso-occlusive pain only, followed by chronic vaso-occlusive pain from organ failure, such as hips and ulcers and the like. And then at some point, maybe, a transformation occurs, adding this central or neuroplastic component. That complicates the approaches to all therapies in sickle cell disease, both for acute and for chronic pain. Opioids have been studied, but not studied well in this mixture. Non-opioids have not really been studied. Biobehavioral techniques are strongly recommended, but underfunded and understudied. And there may be genetic predispositions to this, but the map of the genetic influences includes approximately 100 genes. So this is just a cartoon that I developed around 2010 to say what I said a few minutes ago about the possible evolution of chronic pain. On the left-hand side, on the right-hand side, you see 4 kinds of pain: vaso-occlusive pain from a typical crisis, nociceptive pain from bone and tissue necrosis, neuroplasticity, which may or may not occur, and even opioid-induced hyperalgesia for patients who are given opioids chronically. Here's the definition for chronic pain that the consensus panel came up with. We settled on ongoing pain for more than half of days in the last 6 months. We allowed 3 diagnostic modifications. The so-called neuroplastic pain alone would be diagnosed as chronic pain without contributory disease complications, but you could have mixtures, or you could have chronic pain from vaso-occlusive phenomena, as we discussed. This is not making a etiologic diagnosis, but it is trying to give some clarity as to how to classify epidemiologically these kinds of syndromes. Phenotyping is very important, as you can imagine, in trying to do trials. So here's the evidence topic table that I came up with without filling it with the actual evidence. I said that the efficacy of acute opioids to reduce acute pain during a single vaso-occlusive episode in unselected patients was, there was good evidence for what to do there, but more evidence needed to be developed. And by that I meant that the emergency department evidence is the strongest, the analgesia within 30 to 60 minutes of arrival, whereas the inpatient evidence is less strong. We need more randomized controlled trials of inpatient strategies for administering opioids. Variables could include oral versus parenteral, time variability, etc. I said that harms of acute opioids to reduce acute vaso-occlusive pain during a single vaso-occlusive episode, that the evidence is available there. In the randomized controlled trials, there were some harms, but there's also good, strong survey and cohort evidence. For example, deaths due to opioids from sickle cell disease over the last 10 years have been about 1/10 of the deaths from opioid use due to migraines. I said that the emergency department, again, it's clear what to do, and that we need, again, more inpatient trials of opioid administration strategies. I said that the efficacy of acute opioids to reduce acute sickle cell disease during a single vaso-occlusive episodes in patients with or without chronic pain is an important distinction, that this evidence has not been developed, that all the evidence so far has not distinguished these patients, and that acute pain without chronic pain was a clear pathway to go forward, whereas acute pain in the background of chronic pain studies might be infeasible because teasing out acute pain is so difficult. I then said that behavioral strategies to implement these best practices fall far from adequate. There's not great evidence available, that's some evidence available, and that evidence suggests that the techniques that we've tried, implementation science techniques, have not been successful, and we need more development in that area. And then last, I said that opioid reduction in exchange for disease modifiers, even biobehavioral strategies, is another area where there's very little to no evidence. Some of this will be dependent on the FDA approval of acute disease modifiers. Others would be dependent on normal clinically use of biobehavioral techniques, biofeedback, and the like. One of the discussion questions was, what other types of studies might be easier to do than randomized controlled trials, and would they help with understanding opioid prescribing? And I said that we have a phenotype problem. We're early in the study of pain and sickle cell disease. This field is far behind many other well-studied diseases, acute and chronic. So we need better patient-reported descriptor evidence, more quantitative sensory testing evidence, more imaging evidence, including functional magnetic resonance imaging evidence, and we need animal studies conducting probes of various opioids and non-opioid therapies in phenotypically well-described subjects. In 2011, we were asked to review this evidence for the Interagency Pain Research Coordinating Committee and found that the number of pain grants for sickle cell disease was far below that for any other pain condition, and that basic and translational research in sickle cell disease was far less than that in other conditions. The portfolio you can see before you showed about 13% of studies focused on pain outcome assessments and measures, about 11% on health disparities, about 7% on genetics and genomics, about 7% on medical management, which I find very interesting. That's a small number. And about 7% on pharmacological mechanisms and treatments, and then 9% on development of animal models. So the gaps and opportunities are pretty obvious. Better phenotypes and case definitions, more devices, more analgesics, better delivery systems targeted at these mechanisms. And in 2018, most of you know that the Federal Food and Drug Administration, along with the American Society for Hematology, held a sickle cell disease clinical endpoints workshop designed to try to better inform the conduct of sickle cell disease clinical trials. The main outcome of that was we're still early in the game, that there are challenges in developing clinical endpoints for sickle cell disease trials of all kinds, including pain trials. There are no validated biomarkers. Existing clinical trial endpoints often don't distinguish between acute and chronic pain, and I've tried to emphasize that in my talk today. Pain scores are subjective. Opioid use may not be under the patient's control, and hospitalizations are often influenced by the social determinants of health. The general guidance from the NIH and the FDA is here. There is a Interagency Biomarker Working Group and a website called the BEST resource, where these biomarkers are described and as they are discovered can be logged. Here is the obligatory possible clinical endpoints for sickle cell disease, vaso-occlusive crisis, hospitalizations, pain diaries, that's my area of expertise, pain scores, opioid use, inpatient and outpatient. And then for laboratory markers, markers of pain and inflammation, including substance P, markers of hemolysis, including free heme, markers of vascular damage. Sickle cell is a vasculopathy, and so it has significant nitric oxide and VCAM changes during an acute episode, and comparing sickle cell patients to normal patients. And then markers of rheology, the flow in a red cell. There can be non-invasive markers, can be microscopic study markers, and there can be, in this day and age, you can actually do markers of flow and functional flow with time through the venule or time through the capillary studies. Discussion question formal 1, could the draft framework be used to develop a clinical practice guideline? And I said that the framework best applied to acute sickle cell disease pain without overlapping chronic pain, and that the framework was less applicable when complications occur or when there is chronic pain as an underlying subtext. What evidence would be necessary to make these links? And I said that the knowable thing is step 1, where randomized controlled trials could easily be done and more are needed. And then the frameworks 2 through 5 were not completely knowable. Links were not completely knowable unless you were looking at a single acute vaso-occlusive episode. And I already showed you that these occlusive episodes are rapidly repetitive in some patients, rarely repetitive in others, result in chronic pain in others. How might the evidence be generated if one were going to do inpatient randomized controlled trials for single vaso-occlusive episodes? This is a list of 2 or 3 good studies that use the template that I would recommend. How would you conduct studies for conditions where the randomized controlled trials are impractical? And it gets muddy here because it's a rare disease, hard to find these patients, hard to get them to say yes, they're not trusting, they're stigmatized. There's a clinical trials network being formed by the American Society for Hematology. There's been a federally funded clinical trials network in the past, so networks are good. You need 20 to 50 sites to do most studies, and each site will contribute anywhere from 2 to 30 patients. You could do nested randomized controlled trials as part of longitudinal studies, either currently funded or about to be funded, such as the UO1s that were recently funded at NHLBI, or PCORI-funded studies for transitions of care. And you could try to get cooperation between various sponsors of these trials so that man months are spared during the trial enrollment. How can the practicality, dissemination, and uses of these clinical practice guidelines be improved? Difficult because of the many competing goals facing practitioners with patients with sickle cell disease in the clinic or in the hospital. Opioid safety is paramount these days. Patient satisfaction often is pushing physicians in the opposite direction from the minders who are concerned about opioid safety. We have a subjective symptom, difficult to get objective measures. We have the need to adhere to all federal, local, and state statutes. We'd like to avoid misuse, and we'd like to also remove stigma so that there's no underuse, and that there's better adherence to clinical practice guidelines that are already published. Are there prescribing nuances? You bet. Many, and I've just described most of them, and I'll stop there.